Outside, I'd like to thank AIOS for this chance. A very good morning to judges, to my colleagues. I'll be presenting on pain management protocol and PRK and post cross-linking, a novel concept of how using cold BCLs we change the way we manage post PRK pain. So I think all of us know about PRK being a good procedure, no doubt, especially in cases which are not suitable for a flap-based procedure. But in from time immemorial, we obviously know that there are two aspects which do bother us when we're looking at PRK. One aspect being the post PRK pain, and the next aspect being the post PRK haze. So how do we address this? There's always been a lot of work on how effectively we can manage post PRK pain. Topical analgesics, these are known facts, but surface toxicity is always a risk. Oral analgesics, well, there are a lot of effective oral analgesics, but the challenges, especially in the immediate post-operative period, how do we effectively manage pain so that they have better compliance to these medications. So we want to know whether there is an effective non-pharmacological means of pain management, and that is where we based our study on. Now our work, we have published earlier on pain management after PRK, where in comparison to a conventional bandage contact lens, we soak the bandage contact lens in 0.45% ketorolac, and what we found is that there was much better post-operative pain factors in terms of something which is known as the Wong-Baker scale. So we wanted to know and move further is that can we build a better way of looking at post PRK pain, and what we dealt and looked back at literature is the role of cold or role of cryotherapy. So there is a lot of things, cold or using cold packs for treatment of pain. We wanted to extrapolate that concept of using cryotherapy or using cold into trying to manage post PRK pain. And our research question was, can we use cold thermotherapy in the form of refrigerated bandage contact lenses to manage post PRK pain? So we looked at a cohort of 202 PRKIs, 249 patients who were keratoconus, who had underwent cross-linking. They all underwent the routine clinical evaluation and diagnostics. What we did is randomize them into 4 groups. So we, one set of patients had the conventional bandage contact lens, which was given immediate post-operative. The second set, conventional plus ketorolac. So we've already published that. Now what we added on is looking at how we can use cold or refrigerated BCLs. So group 3 had just a refrigerated BCL. This is stored at 4 degrees overnight in the refrigerator, and the 4th group was cold with ketorolac. So we wanted to find out is using cold bandage contact lenses, could that make a significant difference in outcomes in terms of pain? What was normalized in these cases is that all of these patients underwent cold BSS wash. It was randomized, and the pain scoring on the Wong-Baker's faces pain scale was recorded on day 1, 2, and 3. Interestingly, when we compared and looked at, the pain scale, which is post-operative after either PRK or cross-linking, we found that there was a significantly low, scores, which is on the pain, which is suggestive of better or lesser pain in the cold group. So that is the cold plus the ketorolac and the cold BCL itself, as in comparison to the conventional bandage contact lens. What is also important is that the addition of ketorolac, whether it is in the conventional plus a ketorolac or the cold bandage contact lens with a ketorolac, did not actually cause a significant difference. So it's in fact the cold or the cold BCL, which itself was significantly better in looking at pain which is post-operative, either post-PRK or post-keratoconus. So even in the PRK group, we found a similar trend. We wanted to go further. We didn't want to restrict ourselves. What exactly are the factors which are driving and helping us looking at patients reducing or decrease in pain immediately post-operative PRK? So there has been a lot of work on these these are temperature-sensitive channels which are there on the ocular surface. So a few of them to name is the cold temperature-sensitive, which is the TRP, which is the transient receptor potential melastatin A. So these are actually activated by cold itself, and these are gated ion channels and have an analgesic effect. The TRPV1 to say is a heat receptor protein. This is again a gated ion channel, and that is activated by heat. Many of these factors are, indirectly related to temperature or indirectly related or activated with inflammation immediate post-operatively. What we did is we took the bandage contact lens and replaced them on day one, and we put that in something known as a phosphate buffer saline, where we did a microcentrifugation and we did a qPCR to look at these various factors which can actually change in the interim or the immediate post-operative period. And what we found, interestingly, is that there was an increased absolute and relative expression of the TRPM8. So this is a cold sensitive ion channel, and this was increased in those patients who had reduced pain with cold and BCL. What is important to note is that the cold actually triggered this kind of a gated ion channel, and this was the reason where probably was the reason as to why they had a better decrease in pain post-operatively as compared to those who did not. So to summarize, there was reduced average pain. We found that there was an increased absolute and relative expression of these specific cold receptors. Now, the question which everybody would obviously ask is that how long will the cold actually last? I mean, you're just taking it out from the refrigerator. The main aim is that it dampens the immediate post-inflammatory insult, and that is what is important to remember, and increases the compliance to suitable post-operative analgesics. So this is a simple technique. There's no added risk of contamination, but yes, the Wong-Baker is a subjective analysis. Thank you for your patient listening.
Do you think using some cold packs over the eye might be an additional, and did you look at something like that or think of something like that?
Cold packs, yes, but the logic is this is at least for the first 2 or 3 days. It'll be at least in the immediate one day there would be a cold pack, cold BCL over the eye. And what we did is we replaced the bandage contact lens, which was the same way. So if it was a cold bandage contact lens, on day one we again replaced it with a cold bandage contact lens. So our logic is that the immediate post surgery inflammatory surge is being dampened. Now, no doubt that cold is not going to last for a long time as soon as you take it out of the refrigerator. This is still a hypothesis as to plausible reasons as to why they have a better tolerance than a patient who does not have a cold BCL. But our logic or hypothesis is that because the immediate inflammatory surge is dampened, therefore their response to the routine anti-inflammatory agent. So it's not that we are going to stop them off on NSAID post-op. It's just that we're giving this and continuing that with a non-steroidal anti-inflammatory drug and oral analgesics, which can maybe have a better role.
You think that putting these eye drops post-operatively at 4-degree temperature and put it in the eye in the first few days, the cold eye drops, that
so
probably might help you also along with this.
Could be.
The drops at 4 o'clock for 4-degree temperature and use the same drops.
We could. So, I mean, even cold BSS is the reason as to why we are, doing a wash. So, there are various targets as to where we can actually alter and look at temperature. What we looked at specifically is the bandage contact lens. What you're saying is something which could be done, but try to negate it. What we did is, the cold BSS was common for all of them. And what we found is that in the group with the cold BCL, there was a significant decrease in pain. So this is still a work in progress. A lot of factors and determinants are still unknown, but this is interesting results to start off with. Yeah. Thank you, sir.